Okay.
Hello, Dr. John. How are you?
Hey, Omar, how are you?
I'm fine. I wait. Hope not.
Everything,
I think,
everything calm?
inshallah. What do you got? I think there's a webinar at Cairo. Egyptian?
There's also a conference in Cairo. Yeah, we're televising that too on another channel.
Yes, yes. I think because
Let-
Cairo now
let
with
me
now.
let me check it now. Okay, excuse me for a second.
Also skull base, oncology and skull base.
Oh, I gotta. Okay, yeah.
I wait after. I am here with you.
Okay. Yeah, I'm gonna do that. Hey, James,
Hello.
how you doing?
Good. How are you?
Good. I'd like you to meet Takashi Khan. He's translating into Japanese. Good morning, Takashi.
Good evening. Good evening.
Good evening
Dr.
in
Liu.
good evening in
Good
Japan.
evening. Nice to meet you.
This is Dr. Liu. Dr. Liu.
Dr. Liu, nice to meet you. Dr. Kon from Tokyo, Japan. I met you during the cadaver course in Florida in 2003 or 2005. I was in Duke. So
Oh, okay.
I met you at the time, cadaver dissection.
Oh, great. Great. You
Yeah.
were with Dr. Fukushima?
Yeah,
the time?
I learned from Dr. Fukushima. But I went to Duke as a research fellow, but I attended the cadaver Florida dissection to learn from Dr. Fukushima. So I met you several times. So I talked with you with Japanese fellows.
Yes.
You were great. So you had many good experiences. So I admire you so much.
Thank you. It's good to see you again.
Let's do it again.
You are now in Tokyo?
Yeah, now in Tokyo and Showa University, and I am doing my malignant brain tumor. Mainly I'm doing malignant glioma,
Okay.
glioma surgery and chemotherapy.
Good. Good.
Danu, are you there? Danu, have you stepped away, I guess? Possibly. Yeah, Juha should be here in a minute or two. So Takashi, how you been? Have you been translating somewhere else?
I invite several some of my friends. So they're using YouTube or some other lines. So as using some WhatsApp, we use Japanese one.
Because we have a couple coming up, so I'll let you know
Yeah.
about them to see if
Okay,
you,
okay.
if
John-
you- if you
John.
want to do it. Yes.
John, so how does this work? Do I hear them translating, or do I just keep going at my own speed?
Oh,
or
no,
do-
no, oh, no, no. You don't even know they're there.
Oh, okay.
They're put on silent. And
Uh-huh.
what he does his own Zoom on his laptop. So you will not hear him.
Okay.
He'll just be like a silent panelist.
Okay. So I don't have to pause for him
No.
to translate each sentence.
No, we really haven't, done any of that. So just do what you
Yeah.
normally do. you
Okay.
know.
Okay.
So I'm sure they're used
Yeah.
to, and the neurosurgeons, obviously, so they'll be better. Not, as the same language, but at least it'll be the best translation a neurosurgeon can get.
Yeah. Yeah.
Because there are a lot of terms
Yeah.
that the regular translator
Yeah,
won't know or have any idea.
I did a lecture live once in Beijing, and I had to pause after each sentence to wait for their translation. Yeah, it was
Oh,
interesting.
okay.
Yeah.
I'm not familiar with that. Here's Ben now. He's coming.
Yeah.
Hello, Ben.
Hello, John. Hello, James.
Good morning.
Hi,
You
Ben.
know,
Hi.
you met Dr. Leo before, Ben?
Yes.
Oh, okay.
Actually, we met several times, and
I think we maybe met maybe the Suns meeting 2015.
yeah.
It was in your hospital.
Yes.
Hosted by your hospital. Yeah.
Yes.
Where are you at, Ben? Are you between operations?
No, I'm in car.
Oh, okay.
I'm in Shenyang, another city.
Oh, okay. Are you going to
Yeah.
do the translating, or is your associate?
Yes.
Okay.
Don't worry, we already arranged.
Yeah.
Mhm.
Sometimes the translator forgets and leaves their mic open, but that only happened a couple times.
Mhm.
But yeah, Dr. Leo was asking, does he have to speak slowly? So
It's okay.
I said that I haven't heard of any advisories concerning that. Yeah, James, I thought Juha would come a little. This is the first week he hasn't come early.
Maybe he's still operating.
I don't know. I don't think so. This is like a night in China. This is a big deal to him. So he'll be here. Yeah, I get nervous too. What's gonna happen if someone doesn't show up?
How many people have signed on from the registrants already? Like logged in?
Logged in. The panelists a lot come late. We'll probably get 50 or 60 panelists. But watching, there's a lot on YouTube. We really can't measure. But Ben can measure. He'll let us know at the end of the broadcast.
Yes, in WeChat channel, we already have around 700 audience.
Okay, that's good. And we're just starting though. A lot of people join late. Here, let me text you. He's pretty responsive to WeChat. Are you familiar with WeChat, James?
Yeah.
Yeah, I got to get to know it. Well, here's you. Okay.
How are you all, Dr. Takashi, Dr. James, Dr. Ben? How are you all from Syria?
Hello, Omar.
Hello.
Hey,
Good morning.
Assalamu alaikum.
Good salam, wallah.
Assalamu alaikum.
Good morning, Juha.
Hello, John. I'm
How is it?
outside of Chengzhou. That's why we had some difficulties.
Oh,
The We have to
yeah.
connect. So I have to connect with my iPhone. I'm sorry.
Oh, that's okay.
Sorry, we tried with my laptop, but it's not possible from we are outside 4 hours from Chengzhou.
Okay. Okay,
so,
does your camera work
in the
in
Congress,
you? Is your
so-
camera working, Juha? No.
Okay, now
Not yet. Still, I don't have the camera, Juha. I guess we'll just use audio then.
sorry for that.
That's all right. We got a couple of minutes.
It's asking me to access your camera settings or privacy something.
I don't know much about smartphone cameras.
I don't know also, but I will say
Yeah,
short
just
introduction.
yeah, it's okay. Audio is fine. Just the audio is fine. I'll let you say.
I think if you hit that arrow next to stop video, I think it might give you the option to choose your camera.
Yeah, I just keep banging on buttons until.
What's the meeting ID in Zoom?
What is the meeting ID in Zoom, John?
What's the ID number?
Yeah.
Well, you really shouldn't need that. What do you need the ID number for? Usually the
Because
camera.
it is asking here. It is asking here.
The ID number. Okay, let me see. Well, okay, 893 6770 4352.
Did you get it?
You got that number? I'll put it in the text. I'll put it in the. I don't know if you have access to the text.
Amen. Now we are close. With this number, we are close to getting.
893.
No.
670.
Join the webinar.
I'm putting in the chat now.
Repeat the webinar.
435.
Can you repeat the number once more?
Okay. 4352.
4.
Okay, I put it in the chat. Okay, do you see it?
No, it doesn't. We don't have chat. I cannot see.
Okay.
It's beginnings.
Yeah, it's 893 677 04352.
Yeah, we got it. Yeah. Thank you.
Okay. We'll start a minute or two late.
Yeah. So.
Okay, Juha, you ready? 0, 4, 3.
Wait 1 minute if you can join with my laptop.
Okay, okay.
1
Hello,
minute. Otherwise, we can begin.
No, I'll just wait. Just wait.
hello, Dr. Juha.
Minute or two.
Hello, Victor.
Good morning, Victor.
Dr. James, nice to see you.
Okay,
Greetings
Juha, you
from
ready?
Mexico.
0,
Good to see you, Victor. Nice to see you again.
I'll join with my laptop.
How are you,
okay.
Victor? How are you?
1 minute. Otherwise, we can begin.
Evening.
No, I'll just wait. Just wait.
Hello, Dr. Juha.
Okay,
Hello?
someone has their YouTube on. You got to get off the YouTube. I can hear it.
Professor Juha, how are you?
Okay, let me.
Dr. James, nice to see you.
Okay,
Greetings
Juha, you
from
ready?
Mexico.
Good to see you, Victor. Nice to see you again.
I'll join with my laptop.
How are you,
Okay.
Victor?
Okay, Juha? Can you hear me, Juha? Okay, I think he's hooking up. Okay, we'll just wait till he hooks up to his laptop. We're just waiting until Juha connects. I think he was connected on a smartphone.
Oh, his video is here. Yeah.
Oh, there you are. There you are, Juha. Can you hear me, Juha?
Just keep the noise. Thank you.
I can see the audio working, but okay. We're watching him set up. Yeah, he's key, James. He moderates, so. Okay. Can you hear me, Juha, now? Yeah. Okay, now you got the mute button. Unmute yourself. That's a good sign. Yeah,
I have to use my iPhone.
Okay, can you
hear me now?
Yes, we can hear you.
Okay, let's begin now.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, it's Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We have the pleasure of having James Leo, a neurosurgeon from New Jersey, and Juha is going to give him his proper neurosurgery introduction. And I'd like to welcome especially the Chinese neurosurgical community. It's being live streamed in Japanese and Chinese. Okay, let me introduce. Nope, someone's YouTube is on.
Okay. Can you hear me now?
Okay.
Yes, we can hear you.
Yeah, somebody has a YouTube on.
Okay, 10, 9, 8, 7, 6, 5, 4, 3.
Okay, Juha.
Good
Okay,
morning.
Juha, it's all yours.
Okay, dear all, I'm sorry for the technical difficulties we had in connections. We are outside of Chengdu now, and so in a hotel, so some difficulties. So today we have the great honor to have Professor James K. Liu as a guest. He's the director of skull-base neuro-oncology and cerebrovascular surgery at Rutgers Health, New Jersey. He certainly has done everything what I have told in so many webinars, how to become a good neurosurgeon. It means hard working, and he has certainly done that. And this is extremely important. I have seen his beautiful operative videos, and they are very convincing, and he has also published heavily for his age, more than 200 publications and more than 25 book chapters. And this is certainly numbers will increase heavily in future. So I have followed him heavily, and he's certainly what I called a rising star, and will certainly get more and more patients with difficult skull base and cerebrovascular lesions. So he will give his lecture today. And what I have also noted, he has been speaking a lot against racism, and this is very important subject, and needs to be brave to tell your opinion. So please, James K. Liu, go ahead with your lecture. And
Perfect.
we are waiting for that.
Okay, let me share my screen.
Yes, perfect.
Thank you.
Perfect.
Great. Thank you, Professor Juha. Thank you for that very kind introduction. It's a great honor for me to speak in your grand rounds today.
Thank you.
This webinar forum.
Okay, thank you. So
has been global neurosurgical education stage, many of whom I've called my own teachers and mentors, and so I'm very grateful for this opportunity. So today I wanted to speak about lateral skull base surgery, and when we're doing lateral skull base surgery, there's a fine line between trying to get the best tumor removal and then risking impairing neurological function. So can we achieve both? And I'm going to try to address that question today. These are my disclosures. And so when we look at the CP angle and petroclival region, we can see a variety of different tumors. Here we see an epidermoid tumor. This is a meningioma. This is a hypervascular paraganglioma. This is bilateral acoustic schwannomas, NF2. And then here's a trigeminal schwannoma, acoustic, cystic, acoustic, petrous face meningioma. And then here's a petroclival meningioma with Meckel's cave extension. So a lot of variety of different challenges that you can see here. And there's a variety of approaches to get there. And some can be done through a simple retrosigmoid approach, but sometimes you may want to consider a more sophisticated approach through the temporal bone, through a transpetrous, transpetrosal type approach. But this is the workhorse. This is the retrosigmoid approach that you classically see. And this is from Roten's beautiful dissection, looking at everything from the tentorium down to the jugular foramen. Here's the 5th nerve, 7th and 8th nerve complex, and lower cranial nerve complex. And so when we talk about removing these tumors, there seems to be a fine balance of radical resection and cranial nerve function. And I think there's a myth or a worry that if we're too aggressive or too radical, we can impair cranial nerve function. And some may think it's a trade-off, but can we find a balance? Can we find a balance where we have maximal safe removal or a near total removal and spare cranial nerve function? And I think an area that is often debated is the area of acoustic neuromas. And as you know, for these large COOS grade 4 tumors, our goal here is to try to preserve the facial nerve, but we need to try to achieve a gross total or at least a near total tumor if possible. And this is a patient who, this is post-op day 1 immediately after surgery. And you can see he had a very, very good resection, very minimal residual I left on the facial nerve. And so what we're seeing around the world is this adaptation of the adaptive hybrid surgery. And this has gained a lot of interest with young and old neurosurgeons, where the strategy is a planned subtotal removal followed by gamma knife radiosurgery. And you can see this is the pre and post-op scan. And this was published not too long ago in ACTA. And there's a lot of criticisms. And one criticism is that it's allowing non-specialized centers and perhaps less experienced surgeons to attempt to remove these large tumors. And this can cause some difficulties for the patient. This is a classic example. This is one of my own patients, very large tumor, significant brainstem compression. This was treated by a neurosurgeon in the community who's not a skull-based surgeon. And this was the post-op scan. It looks just like the pre-op scan. And the patient's family was told, we got most of it, the rest is inoperable, we can shrink it with radiation. And so the patient got radiation therapy, and then 3 months later was quadriplegic, quadriparetic, laying in a hospital, and was told by the internal medicine team that this patient is ready for hospice care, end of life care. Fortunately, we were consulted, and we took a look at this scan, and we transferred to our medical center. And we went ahead and I went ahead and did translabyrinthine approach because I felt this was a nice approach to avoid excessive brain retraction. And because of the radiation, there was facial nerve adherence. And so I left a thin carpet along the course of the facial nerve. And this scan up here is 9 years post-op. And it's been stable. And she went from being quadriparetic to ambulating at 2 months standing, 6 months getting better. And then she's still alive and well, living a normal life at 9 years post-op. So if we look at the literature more carefully about this subtotal removal approach, some people have written this systematic review, and they call it a nerve-centered approach because they feel that we are sparing the facial nerve. But if you look at the studies very carefully, the tumor removal is primarily intracapsular, okay? And the short-term follow-up is short-term, but the results look favorable. Very good control rate of 94% and facial nerve preservation, 96%. And these results look favorable, but we have to ask ourselves, are we doing the best thing for the patient? And so some of my own personal criticisms is that if the resection is subtotal and it's predetermined before even going into surgery, it's basically saying, I'm not going to even try. And the debulking is primarily intracapsular, so it's difficult to assess how much you're actually removing, and actually you end up underestimating how much residual tumor is there. And there's a huge spectrum of subtotal removal, and I'll show you in a moment that not all subtotals are created equal. This type of strategy is lacking long-term follow-up, so we don't know what's going to happen in the next 10 to 20 years. And will we be treating a new type of emerging disease that's been radiated? And are we forgetting how to do safe and proper microsurgery. And microsurgery is now become a lost art, because if our teachers are not doing high-level microsurgery, how are our students going to do this in the next generation? And so they're not going to be able to tackle these types of difficult tumors and lesions. So I think just like cerebrovascular surgery, microsurgery of the skull base is becoming a lost art, unfortunately. So we have to learn how to preserve this craft. So this slide shows you that not all subtotals are created equal. This is a scan where there's a linear enhancement where I know as a surgeon I left a little bit on the nerve because I didn't want to injure the nerve. And on the post-op MRI, it's barely visible, maybe a linear enhancement. This is slightly thicker. I call it the carpet. And then this is, if you leave a chunk, this is certainly at higher risk of recurrence. So how can we achieve this maximal resection and still achieve the best facial nerve outcome? So my personal strategy and philosophy is that you need to go into the surgery with the intention of a gross total, that you will say, I'm going to do my best to remove as much as safely possible. And if I have to leave residual, it's made based on an intraoperative decision, judgment on your findings, on the adherence of the tumor. And so we need, if we're going to leave tumor behind, we have to leave the least amount of residual while preserving facial nerve function. And this will maximize the extent of resection so that we achieve a radical near total or radical subtotal. One of the techniques that I think is very helpful is this one that was described by Sasaki, which is the subperineural plane of dissection. And what this is that the vestibular nerve encirculates the tumor. And in areas where it's stretched, it's very thin, and there's a thin membrane, and sometimes even some vestibular nerve fibers that protect the tumor from the facial and cochlear nerves. And so when it's very thin, it looks like this clear membrane, and it looks like arachnoid, but it's actually not arachnoid. It's actually thin perineurium. But this plane provides a layer of a buffer to protect the facial nerve. So here is a retrosigmoid approach. We've drilled out the IAC, and we're isolating the lateral pole of the tumor, and we start to peel the tumor from the IAC. Now we're going to work on the medial side, and this is arachnoid. We're mobilizing the arachnoid from the tumor capsule. We'll debulk the tumor to collapse the tumor so we can come around extracapsularly. And here is the perineurium. This is on the inferior pole of the tumor. You see the clear membrane. You can follow it around the tumor capsule. So I call this technique undressing the tumor, like peeling an onion. So you peel this perineurium from the vestibular fibers and you undress the tumor. So you work directly on the tumor capsule. And now we'll find the plane on the superior side. We're peeling this onion and peeling the vestibular fibers away from the tumor capsule. And so now the tumor is at the porus acousticus. This tends to be the area where there tends to be most adhesions. But in this case, we're able to achieve a gross total removal. And so by the end of the tumor removal, it will look like a glove. The fibers at the base looks like a glove. And typically you won't see the facial nerve in most cases, but you have to trust it's there and you can stimulate it. And I also use motor evoked potentials of the facial nerve to confirm its continuity. And so here's the initial post-op scan. He was a Brachman 2 initially after surgery, but by 6 weeks, it's a very rapid recovery back to normal. Here's an example of a translabyrinthine approach. Here the tumor is being removed in the presigmoid space. This is a cystic schwannoma, so they tend to be a little bit more challenging, a little bit more adherent, and occasionally can be more vascular. Sometimes there can be vessels that run through these cystic components, so you have to be careful not to injure the AICA. But now we're we're defining that plane. We're peeling the tumor from the brainstem, and we use sharp dissection to incise the adhesions from the tumor, from the brainstem. And then I use a fine microbayoneted forceps to separate the tumor from the brainstem, defining that plane. And then a lot of sharp scissor dissection. Now here's the facial nerve. We're finding excuse me, that was the lower cranial nerve. We're peeling the tumor from the lower cranial nerves there. And now here's the facial nerve in the IAC. This is a translabyrinthine approach. This is the distal control of the facial nerve, and we're peeling the facial nerve from the tumor capsule, and we can carefully dissect it away very gently. And then here are some adhesions that you have to use sharp dissection and release the facial nerve so you don't cause traction. And I often use the McElveen knife, which is this right-angled ball tip hook with a knife blade. And then as we gently spread, we'll incise the adhesions, debulk the tumor to cause the tumor to collapse. And then this gives you a better mobility of the tumor by shrinking it with the ultrasonic aspirator. And then carefully finding that plane so that we can come around. Now here's the final attachment. You can see there's a little microscopic remnant on the nerve. And here I'm just going to leave a small remnant and then incise it sharply to release the tumor, and then peeling it away from that plane. And then here's the final area of attachment. Here there's a small vessel going to the tumor. Now, if there's bleeding in the resection bed, I advise not to coagulate because you can injure the nerve. So a little bit of Surgicel can control the hemostasis, and you can still stimulate the facial nerve at the end. So this is the repair method that I use for translabyrinthine approach. I use a fascia lata tacked interrupted that creates a net or a sling. And then you can put the fat graft on top of it so that the fat does not touch the brainstem or touch the facial nerve. So this is the patient immediately post-op. You can see a radical near total, but a House-Brackman grade 1. And these are a bunch of different size tumors. These were near total, a gross total on this one, and all House-Brackman grade 1. And then large tumors, Coos grade 4. These were all near totals, and House-Brackman 1 and 2. So what we're seeing is that if they do have a little facial palsy, they recover very fast, as early as 6 weeks instead of your typical 1 year. And so I think this type of technique really buffers the facial nerve and protects it, and gives you this type of result. So this is one of my earlier cases about 12 years ago, and this was a Brackman 3, a little less than optimal result. And I think over time we've improved on this using this technique. So here's our facial nerve outcomes, our last 95 patients. This is using this technique. This is 95% Brackman 1 and 2 outcome. And so I wanted to touch a little bit about the lateral skull base approaches. And, although the retrosigmoid is the workhorse, you have other options that you may need to use in your armamentarium. And so you need to master the temporal bone. And mastering the temporal bone is like being like Michelangelo. And this is the unfinished works of Michelangelo in Florence at the museum in Florence. And you could see that as Michelangelo, he's able to see the finished product embedded in the rock. And when we're drilling the temporal bone, we need to be like that. We need to envision the anatomy that's in the petrous bone and then uncover it like an archaeologist, and like an artist, uncover the structures. And so when we talk about approaches to the clivus, I like to use this method that my friend Jacques Morcos taught me, which is dividing the clivus into fourths. And so if the lesion is in the upper fourth, we typically use an FTOZ or subtemporal approach. And as we go lower on the clivus, between the 5th and the 7th nerves on the brainstem, the Kawasi's approach or anterior petrosal approach is a very nice way to access that corridor. And as you get lower on the clivus, I typically will combine it with a posterior petrosal approach, making it a combined petrosal. And then the lower fourth is typically addressed through a far lateral transcondylar approach, typically for foramen magnum meningiomas and pica aneurysms. And let's not forget the workhorse, which is the retrosigmoid. And then more recently, we can treat some lesions endonasally through a midline endoscopic endonasal approach. So here's an example of a meningioma. This is a petrotentorial meningioma using a retrosigmoid approach. We do this in the lateral park bench position. And here we drain the CSF initially and open the arachnoid and then debulk the tumor with an ultrasonic aspirator. And here you can see the tumors are attached to the petrous and tentorial junction, and there's a hyperostotic suprameatal tubercle that we drill down, and then this gives us more anterior access to the tumor, and then we devascularize the tumor, debulk the tumor, and once it's debulked, we can collapse it and then begin to dissect it away from the critical structures, and then hopefully eventually detach the tumor from its origin, in which case this is coming from the petrotentorial surface. So there's the 7th and 8th nerve complex. This is all above 7 and 8. And we're peeling the tumor off the brainstem, and here are the trigeminal fibers. You can see the rootlets of the trigeminal nerve that's being displaced inferiorly down to the level of 7 and 8. So you know that this origin is from the petrous tentorial junction. And so here's the last component, removing the tumor. And then there's the 6th nerve down by the clivus. There's the basilar artery, and there's the 5th nerve overlying the 6th. And then there's 7 and 8 and the lower cranial nerves and the brainstem. There's the 4th nerve by the tentorium, and here's the repair. I often will use a fat graft to cover the dural opening. And then here's the final view, and the patient was neurologically intact. So that's the standard retrosigmoid, but sometimes you have to use, in my opinion, more advanced approaches, and there's a lot of advantages to that, and I'll show you why. And while the retrosigmoid is the workhorse, I think we have to continue to keep these transpetrosal approaches in our armamentarium. And so when we talk about transpetrosal approaches, we talk about anterior versus posterior. The anterior is primarily a middle fossa approach through the anterior petrous resection, and it gives you a middle to posterior fossa trajectory by cutting the tentorium, whereas the posterior petrosal is primarily a pre-sigmoid approach, working through a mastoidectomy and subtemporal craniotomy. So this is the anterior petrosectomy illustration. You can see if you open up the porous fibrous ring of the porous trigeminus, this gives you access to the Gasserian ganglion and Meckel's cave. And the major advantage in my mind is that this approach allows you to land on the brainstem in front of the cranial nerves. And I'll show you some examples of that. And it gives you this antero to posterior angle of attack to the brainstem without retracting the cerebellum. So when we talk about the middle fossa, the best way to navigate is not with intraoperative navigation. It's best navigated with anatomical landmarks. And so Dr. Fukushima described the rhomboid structure that is bordered by V3, GSPN, arcuate eminence, and then the medial petrous ridge. So you visualize in your mind this rhomboid. So when you bisect the rhomboid, you know where the IAC is located, and anteromedial to this imaginary line is the cochlea. So as you're drilling the petrous apex, you have to keep in mind where the cochlea is, where the horizontal petrous ICA is, and then the arcuate eminence, which can be a landmark for the superior semicircular canal. So you have to preserve all of these otologic structures. You have to have what Dr. Roten taught us, to have X-ray vision, to look beyond the bone, to know where these structures are. So when you're excavating them, you don't injure them. And so as you excavate them, as an archaeologist, you uncover the ICA, the GSPN, the cochlea, the IAC fold, and the clivus. And if we mobilize V3 anteriorly, you'll see that there's hidden bone underneath the trigeminal ganglion, and there's more petrous apex to drill to get more distance. And you can even mobilize the petrous carotid artery from its canal and then remove this bone below the petrous carotid artery. And in some cases of chondrosarcomas that extend into this area, this technique can be quite useful. And we published this technique some years ago with my mentor, Dr. Coldwell, on exposure of these petrous ICA in preparation for the petrous to supraclinoid bypass. And this technique has largely almost extinct because these cavernous aneurysms are largely treated with flow diverters nowadays. But it's important to know the anatomy, and it's important to know your options. And so when we open the dura subtemporally, to get to the brainstem, you have to cut the tentorium, you have to open up the posterior fossa dura, and you get this beautiful access between the 5th and the 7th nerves. And this is very useful for brainstem cavernous malformations in that area. You can get down and open up Dorello's canal. Remember that Dorello's canal is a confluence of venous sinuses where the superior and inferior petrosal sinuses meet the posterior cavernous sinus, and it forms a tube, a dural tube where the 6th nerve will run through before it reaches the cavernous sinus. So that's Dorello's canal. So here's an example of a meningioma that's occupying the supra and infratentorial space. If you look on the Fiesta scan, which I often do to look at the location of the cranial nerves, the tumor origin is medial to the 5th nerve. So this makes this a true petroclival meningioma where the origin is medial to the 5th nerve. And that's very important. So you'll see we'll do a standard frontotemporal craniotomy, and we'll do a Kawasi's approach. And the first step is to ligate the middle meningeal artery at the temporal base at the foramen spinosum. And then we start the peeling of the dura propria from the base in a posterior to anterior fashion to identify the GSPN. And I truly believe posterior to anterior is a safer method, although some have advocated the opposite. But now you start to peel the dura propria off of V3, and it's basically peeling the 2 layers, the interdural layers of the cavernous sinus, peeling the dura propria, which is the temporal lobe dura, away from the periosteal layer overlying V3. Often there are sharp adhesions, so you have to use sharp dissection to peel this off. And I'll often drill the foramen ovale to decompress V3. And this technique allows you to mobilize V3 a little bit more liberally without causing traction injury. And then I've identified the middle fossa rhomboid. And in my mind's eye, I know where the IAC and the cochlea are. So I can now begin the drilling from a medial to lateral direction. I'll mobilize V3 to find the trigeminal depression. And then I'll use a high-speed diamond drill, usually a 3 or a 2 millimeter diamond with a lot of copious irrigation. And you use eggshelling technique where you thin the bone up against the dura over the IAC. And then we'll go ahead and open up the dura at the temporal base, identify the tumor subtemporally that's on the tentorium. And we'll start with tumor debulking in the subtemporal supratentorial space, and then peel the tumor away from the brainstem. And then here's some arachnoid fibers overlying the brainstem. And so now we're going to cut the tentorium. We start at the free edge, and then we'll start from the lateral edge as well. And now we're going to cut into the superior petrosal sinus. I like to just bipolar coagulate it to seal it shut, but sometimes you can use a suture ligature as well, or vascular clips. But I like to just use the bipolar. I think it's a little faster and less bulky. And then you connect your cuts to cut the whole tentorium to the free edge, and then you have to open up the posterior fossa dura to expose the brainstem. Now we're going to open up the arachnoid, and here is the superior petrosal vein entering the tentorium. We'll coagulate this and divide it sharply, and then we're going to open up the porous ring of the fibrous ring of the porous trigeminus. You do this with a sharp dissection with an 11 blade, and now we can open up Meckel's cave. And we're in Meckel's cave just in front of the Gasserian ganglion. And remember how I said the Kawasi's approach allows you to land on the brainstem in front of the cranial nerves? Notice how we're working all in front of the fifth nerve with a wide exposure. We can get anterior to the tumor, coming from above instead of behind the ear. And we have a wide working corridor where we can carefully dissect the tumor, undress the tumor from its arachnoid investment, and then peel it from the brainstem safely. And here I use a lot of suction dissection, suction sweeping with a little gentle traction, and then remove that final piece of tumor. There's the basilar artery and the brainstem, still invested in arachnoid because the arachnoid will protect these structures. And reconstruction is important because we want to prevent CSF leak in skull base surgery. I'll use a multi-layered approach with a little bit of fat graft, some Surgicel, some more Duragen, like a sandwich, and then a nice vascularized pericranial flap that's pedicled posteriorly. And this patient did very well. A gross total removal, no recurrence after 10 years, neurologically intact. So here's another patient. You can see this is a dumbbell lesion, a dumbbell trigeminal schwannoma. Patient had facial dysesthesia. And we went ahead and did a Kawasi's approach, this time with the transzygomatic variant. And again, we identify the middle fossa rhomboid. We do our anterior petrosectomy using eggshelling technique. And then once we've done the petrosectomy, we go ahead and open up the dura subtemporally, open up the posterior fossa dura, and then ligate the superior petrosal sinus so we can cut the tentorium towards the free edge of the incisura. Here we're opening up Meckel's cave by opening up the fibrous ring. There's the fifth nerve going into Meckel's cave. And then we start the undressing of the tumor by mobilizing the arachnoid from the tumor capsule towards the neurovascular structures. And we'll debulk the tumor. And there's the seventh and eighth nerve going into IAC. So again, this approach lands you on the brainstem in front of the cranial nerves. And so when we're doing trigeminal schwannoma surgery, it is very important to preserve as many fifth nerve fascicles as much as possible to avoid facial numbness, burning numbness, dysesthesias. And so we're preserving the main trunk of the fifth nerve. Here's the main trunk. And we're able to peel this tumor out of Meckel's cave. And here's the brainstem. There's the fifth nerve, Meckel's cave, where the suction is. And this was a complete removal. And he's been recurrence-free for 10 years now. Gross total removal. So here's a 43-year-old with this large CP angle tumor. It does not enhance, but it's bright on diffusion, DWI. So this is a epidermoid tumor. Look how it's wrapped around the brainstem, but look how the cerebellum is wrapped around the back of the tumor. The tumor goes all the way down to the foramen magnum and all the way up to the retrochiasmatic suprasellar space. So what approach would you do to remove this tumor? Can you do this through a single approach, or do you need a combined approach? But my initial approach here was to do the workhorse, the retrosigmoid approach. And because the tumor extended to the foramen magnum, I extended the retrosigmoid to incorporate a far lateral approach. And this got me down to the lower cranial nerves. You can see here's 9 and 10. Here's the 7th nerve, and there's the 5th nerve. And I can tell you the 7th nerve was firing every time I was trying to dissect the tumor. And at the end of the resection, I saw this nerve fiber floating, and this made my stomach sink. I knew I had injured and cut one of the nerves inadvertently, but it's the 6th nerve. So the 6th nerve has hope. So you have to find the other end of the 6th nerve, and you have to repair it. Now, some people have said, put the ends together and glue it, but my preference is that you should put a suture in it because it's more sturdy, it's more durable, because the glue can be washed away by the next wave of CSF. And so you should really put a suture in to secure it. And here we're using a 10-0 suture, and you only need one suture to hold it together. And then you have to tie a knot in a deep hole between the cranial nerves so you don't injure it. So why is it important to repair this? Because the 6th nerve can make a full recovery, and you can improve the patient's quality of life. So once we've sutured it, we rest it on the petrous bone, and I put a little Surgicel and fibrin glue to keep it in place. I often use an endoscope to look into the CP angle, and you can see all the rest of the cranial nerves are intact. So, of course, coming in the retrosigmoid approach, I wasn't able to retract the cerebellum because the facial nerve and the auditory nerve were always irritated. So I tried to use an endoscope to look around this corner, but still you could see there's a residual tumor, small one, but nevertheless, it's at risk of recurrence. So here's the patient at 4 months. And already at 4 months, she was beginning to have partial recovery. And then at 7 months, she made a full recovery of her 6th nerve. Quite remarkable. And it recovered sooner than I anticipated. I was expecting maybe 12 months recovery, but she recovered at 7 months. But unfortunately, at 9 months, you could see the residual tumor has started to grow and now has a recurrent tumor. So now what approach am I going to take to remove this residual tumor? Am I going to use the same approach? Well, I failed in removing that from the retrosigmoid. So instead, I come from the front. I come from a Kawashi's approach to land on this tumor in front of the 7th and 8th nerves. So here is the middle fossa rhomboid. I extended the petrosectomy to include a little bit of posterior petrosectomy. So this is an extended Kawashi's approach. And then I cut the tentorium, and lo and behold, you could see I land right on the tumor, right in front of the cerebellum. So I'm working above the cerebellum. And then there's the tumor in front of the 7th and 8th nerves. 7th and 8th nerves are in front or behind this tumor. There's the 7th and 8th nerves, and there's that tumor that was lodged in that was very difficult to see from retrosigmoid perspective. And then here's the complete removal. 7 and 8 are preserved. And then there's the 6th nerve that I repaired 9 months earlier, and then there's the basilar artery. And then there's the 5th nerve and the 4th nerve, a panoramic view of all the cranial nerves, and then a much better removal this time, 2nd stage, and she did quite well post-op, neurologically intact. So the posterior petrosal as I mentioned before, is a pre-sigmoid approach using a L-shaped craniotomy and mastoidectomy. And as Professor Almefti taught us, we combine it with an anterior and posterior petrosectomy using this double petrosal approach, where we preserve the otic capsule to preserve the hearing. And I use that approach for this recurrent brainstem cavernoma. This patient had a previous retrosigmoid approach by another surgeon in a different city, and then recurred. And then another surgeon did an endoscopic transclival approach through the nose to remove this. And of course, there was incomplete removal. And now the patient has this large recurrence. It's bled multiple times, and he has significant deficits, what I call a straight flush, cranial nerves 7, 6, 7, 8, 9. And you can see he's got facial palsy, and he's got hearing loss, and he's got contralateral weakness. So the lesion comes to the surface anterolaterally on the brainstem. And so in my mind's eye, I can get at this easily through an anterior petrosal approach. Remember that cavernous malformations are associated with DVAs in the brainstem, and you have to preserve these DVAs to avoid a venous infarct. And so I took the patient's previous retrosigmoid incision and I extended it to allow this combined petrosal approach. We harvest a pericranial flap. Here's the video we published in Neurosurgical Focus some time ago. And we'll elevate the dura propria off the middle fossa floor, identifying the GSPN from a posterior to anterior fashion, ligate the middle meningeal artery, and then start the peeling process off of the posterior cavernous sinus. The venous bleeding is readily controlled with a little Surgiflow. We'll begin our anterior petrosectomy, identifying the horizontal petrous ICA. John, if you can mute the audience, if that's possible.
Yeah, okay, just a second.
And now we do the mastoidectomy. There's the incus and the lateral canal visible in the mastoid antrum. And by finding the lateral canal, you can now find the rest of the otic capsule because they're all 90 degrees to each other, orthotic. And so there is the otic capsule, and then we'll complete the petrosectomy, combining the posterior and anterior to maximize the exposure, and then removing the remaining eggshell technique. And so we'll open up the dura subtemporally, and then we'll tie off the superior petrosal sinus eventually and open the presigmoid dura. Here we're looking for the fourth nerve. So when we cut the tentorium, the fourth nerve is at risk. So you always want to identify where the fourth nerve is. Here we're opening up the posterior fossa dura and cutting the superior petrosal sinus after we ligate it, and then lifting up the tentorial edge to look for the fourth nerve. There's the fourth nerve. So you make your cut behind the entrance of the fourth nerve into the tentorium. And once you release this, you can see the fifth nerve has been displaced laterally. And we open up the arachnoid, you can see the hemosiderin stained brainstem. And then now we're trying to open up the presigmoid dura, but you can see the patient had previous retrosigmoid surgery, so there was a lot of scar tissue there. So we decide to do most of our approach here through the subtemporal corridor. So there's the exophytic component of the cavernoma, and then we try to define a plane around the cavernoma using piecemeal resection here. So a little bit of gentle traction, and then to tease the cavernoma away from the brainstem using suction, dissection, suction, retraction, suction, mobilization. So there is the cavernoma being removed in piecemeal. And then here is the other portions of the cavernoma that you have to explore. When there's a recurrence, sometimes these cavernomas, there's seeds of them. It's like seeding. There's a cavernoma that that was left behind more superiorly, that grew. And so based on image guidance, we made a corticectomy through this safe zone of the brainstem, just medial to the fifth nerve. And then we have two corridors now, and this is non-eloquent tissue. So we're going to combine the corridors to get a bigger corridor so we can get the remainder of this cavernoma. And then here's the rest of the cavernoma. And we have to be mindful where that DVA is located. It's going to be in the center of the brainstem, so we're going to look for it. And you can see here's the nice gliotic plane around the cavernous malformation. And it's very fibrous. You know, these recurrent redo cases, a lot of fibrous tissue, so you have to use scissors, sharp dissection to cut the fibrous tissue, a lot of scar tissue. So you need some good heavy scissors. There's the DVA. This is not the malformation, so don't mistaken it and coagulate this. And we'll often use an endoscope. Endoscope is not just for the nose, but the endoscope is for tight spaces. And we can look inside the brainstem. There's the DVA, and there's the fourth and the fifth nerves, and then a nice complete removal. So here's the temporal bone CT looking at the double petrosal approach. Here is the resection, complete removal, and the patient regained his motor function and his sixth nerve, seventh nerve, and his hearing all improved. And he's now a motivational speaker. And so here's the another tumor. This is a petroclival meningioma. We used a combined petrosal approach using this temporal craniotomy with what I call an extended mastoidectomy that incorporates the retrosigmoid opening with your mastoidectomy. We'll do our posterior petrosectomy. We'll do our anterior petrosectomy, combining our double petrosal, and then open up the dura in a subtemporal fashion. And then here's the tumor in the presigmoid space on the right side. This is the superior petrosal sinus that we're going to ligate here with a suture ligature. And then we'll cut the tentorium towards the free edge of the incisura. And what this does is it opens up the space. It opens up this window. There's the seventh and eighth nerves. You can see the tumor is all superior to 7 and 8. And luckily, the tumor was soft and friable as opposed to fibrous. So the fact that it was soft and friable made it a little bit easier to remove. And here we're cutting the rest of the tentorium towards the fifth nerve, towards Meckel's cave. There's the fifth nerve. You can see now we're working all above the fifth nerve, and now we can debulk the tumor more aggressively with the ultrasonic aspirator now that we know where the cranial nerves are located. And then you can see the tumor vascularity is largely from the tentorium. So when you cut the tentorium, you largely devascularize the tumor, making the tumor removal a little bit easier. And then now we can peel the tumor away from the clival area by bringing it down and separating it. And then there's the fifth nerve. We're following it from the fifth nerve. We're peeling it from the brainstem. And you can see a lot of fibrous adhesions here using careful two-handed microdissection. And then there's the final view with the endoscope looking at the resection bed. All the cranial nerves are intact. We'll use a fascia lata sling technique for the repair, and then a little bit of fat graft on top of the sling to prevent CSF leakage. So here's the double petrosal defect. And then here's the post-op scan, a gross total removal, and the patient was neurologically intact. Here's an example of this cystic tumor. Look how it's enhancing. It looks rather treacherous. But this is a patient who presented with left facial numbness and gait ataxia. So this is a trigeminal schwannoma, and you can do many approaches to this, but my preference here is to be able to open up Meckel's cave, and I like to do this through a combined petrosal approach. And we published this in Operative Neurosurgery last year. And you can see we're cutting the tentorium using the standard combined petrosal with preservation of the otic capsule. So when you open up the dura, the first thing is to drain the CSF to allow brain relaxation. And then we're going to look for all the cranial nerves. So there's the trigeminal nerve, and we'll stimulate it to confirm it's not the facial nerve. And sometimes you can stimulate it to look for masseter to confirm it's the trigeminal nerve. So we'll go ahead and debulk the tumor initially. And debulking is good because then you can collapse it and then you can dissect it off of the brainstem. And we're going to look for the 7th and 8th nerves, which is just inferior to the tumor. You can see it on the inferior pole of the tumor there. There's the 7th and 8th nerves. There's the tumor. And then using a good pair of fine microforceps, we can peel and separate the tumor from the cranial nerves, from the brainstem, and then further debulk the tumor. And so this tumor was rather adherent to some of the fascicles of the 5th nerve. And like I mentioned before, when we're doing trigeminal schwannoma surgery, you want to preserve the main trunk and as many fascicles as you can. We're going to look for the 4th nerve, which is going to be here at the top of the tumor. There's the SCA, and there's the 4th nerve. So now that we have identified the 4th nerve, we have more confidence that we haven't injured it. And we'll open up Meckel's cave here. Here's the rest of the tumor in Meckel's cave. You can see it's very adherent to these fascicles of the 5th nerve. And towards the end, we want to find the 6th nerve, which is always going to be the last nerve that you see typically. It's going to be displaced medially, and it's very easy to injure in these cases. And so here we eventually find the 6th nerve, and I can tell you that it was very adherent to the 6th nerve. So I had to leave a small microscopic remnant on the 6th nerve, but very minor in order to preserve it. Here's the last portion of the tumor removed using these micropatties. And there's the basilar artery. There's the 6th nerve, a small residual microscopic adherence. And then here's the endoscopic view of the resection cavity. There's the abducens nerve, there's the basilar, and then there's the 7th and 8th nerve complex, a little small tumor remnant. And in the closure, we'll use the fascial sling technique. I put a little bone cement to occlude the entrance to the middle ear to prevent CSF rhinorrhea, and then a fat graft with devascularized pedicled pericranial flap. And so here's the gross total removal, or near total removal, excuse me. And patient was neurologically intact. Now, can you use the petrosal approach for deep vascular lesions? Here's an example of a hemorrhage. You can see the striations of the fovea of the cerebellum, very unusual pattern of hemorrhage. So you need to suspect there could be an AVM. So here you can see the distal SCA feeding this very small micro AVM, not a large AVM, but a micro AVM that you can see here. And this is in the posterior fossa. So even though it's a small AVM, this can cause a potentially dangerous hemorrhage. So you can do retrosigmoid, but I feel when you have AVM surgery, exposure is critical. You have to have good proximal and distal control. So here, instead, I did a petrosal approach because you'll see in a moment that I land right on top of the AVM with wide exposure, safe exposure, good control of the SCA. So we're opening the arachnoid here. And you'll see in a moment, this is the 5th nerve. Here's the SCA. And look, this is the cerebellum, the quadrangular lobe of the petrosal and tentorial surface of the cerebellum, just juxtaposed to the brainstem. And you can see as I coagulate this feeder, look at the draining vein turn blue. So you see how this is fistulization here? Look how it's blue. Now it's blue. And so now I know where the AVM is based on my intra-op inspection, but confirmed with image guidance. And I begin the corticectomy, and I can begin to identify the AVM, and I can begin to remove it circumferentially. And it's not a large AVM, but you know, it's in a deep location, but this approach made it look like it was very superficial. So I had plenty of room to work. I wasn't worried about a feeder that was going to retract deep into the cerebellum, where I could not visualize or see, but it was very controlled, and it made the surgery quite easily, actually. And so here's the removal, there's the resection cavity, and here's the post-op angiogram showing complete removal. So when we talk about the posterior petrosectomy, there's different variations, and it's based on the hearing status. So if the hearing is intact, we try to preserve the otic capsule and do a retrolabyrinthine variant. But you can also do a transcrucial variant where you remove the posterior canal and the superior canal, also known as the PLPA approach that Dr. Shekar described, or the transcrucial approach that Dr. Delashau, my mentor, described. But it gives you more access to the petroclival region, and you can preserve hearing by not letting the endolymph release as you're drilling the canals. And of course, the translabyrinthine approach gives you the most exposure. And the ultimate is the transcochlear approach, where you mobilize the facial nerve from its canal posteriorly and drill all of the bone around the cochlea and expose the ICA. So this approach we've largely abandoned because this almost always causes a facial nerve palsy that doesn't fully recover, but recovers to a Brachman 3. So we now try to do more of the transcrucial approach, where we drill off the posterior and superior canals and then wax off the opening of the membranous canal, and you get this type of exposure to the petrous apex. And I did that in this large petroclival meningioma. You can see there is a lot of brainstem and cerebellum retraction if you had done a retrosigmoid approach. So I can come in front of the cerebellum and brainstem by doing a transpetrosal approach, in this case using a transcrucial variant. So here we've tied off the superior petrosal sinus. We are working in the left presigmoid area. There's the 7th and 8th nerve, and the lower cranial nerves are down below. And then everything is above 7 and 8 under the temporal lobe. There's a wide exposure. We're working right on the brainstem. There's the 5th nerve, peeling it off the brainstem carefully, combined with sequential debulking. There's the 5th nerve being dissected off. There's the basilar artery anteriorly. And then, of course, we open up Meckel's cave by cutting the fibrous ring of the porus trigeminus. There's the tumor adherent to the 5th nerve fascicles. You can see delivering the tumor from Meckel's cave, how easy it is by opening up that fibrous ring. And then, of course, cutting the arachnoid right on the tumor capsule to undress the arachnoid from the tumor. That allows you to peel the tumor off of the brainstem. And so this is the most superior aspect of the tumor. We're bringing it down inferiorly towards our field using a series of hooks and sharp scissor dissection. And this is nice. This is basically hooking the tumor with the scissors and bringing it down, and then using sharp dissection to cut the rest of the arachnoid. And then there's the top of the tumor adherent to the brainstem. We want to make sure we preserve the 4th nerve. Up here, the 4th nerve can be displaced superiorly, so you don't want to just pull on the tumor. You could avulse the 4th nerve. And there's the 4th nerve. The 4th nerve was wrapped all the way around the top of the tumor, around the back, like a rainbow. So now you've seen the descending portion of the 4th nerve. So sharp dissection, cut the arachnoid right on the tumor capsule, releases the tumor from the arachnoid, which stays with the vessel and the nerve. So I call that undressing the tumor. And then more sharp dissection using scissors, suction. And you can use the scissors to cut and dissect, cut and retract. This is a pretty standard microsurgery. And there is the final view. All the cranial nerves are intact. The fascial sling technique repair, very useful to prevent CSF leak. And then a vascularized pedicled pericranial flap. Here's the final view, near total removal. I left a little microscopic adherence to the trigeminal rootlets that was in Meckel's cave, but you can see on the MRI scan, you don't really see any bulky enhancement, and she was neurologically intact. Moving down along the clivus, let's not forget foramen magnum meningiomas, craniocervical meningiomas. You can see this is partially encasing the vertebral artery in a 270-degree fashion. We'll do this through a lateral, far lateral approach, classic far lateral approach. Take off the hemilamina of C1 to get to the craniocervical junction. And oftentimes you don't need to drill the condyle. The tumor will create the exposure, but I do like to drill the foramen magnum up to the condyle and maybe a few millimeters of the medial portion of the condyle if needed. But I always aim above the hypoglossal canal, so it's a supracondylar infrajugular reduction of that bone because it can obstruct your view. And the first thing is to look for the 11th nerve, which in this case is draped medial to the tumor, and you incise the dentate ligaments so that you untether the spinal cord. And then we'll start to peel the tumor away from the brainstem. And here, the tumor is adherent to the cord. So I'm cutting the arachnoid on the tumor capsule and peeling the arachnoid so it stays on the spinal cord. So this is undressing the tumor here by the spinal cord. So now I can find that plane by peeling that arachnoid off the tumor. And look how the spinal cord is now free. So if you don't do this and you try to roll the tumor, you're going to injure the spinal cord or you're going to cause traction on it. The other pitfall here is the vertebral artery. So you have to find the vertebral artery. Here we're detaching the tumor from the ventral dural attachment, and you have to debulk the tumor so you can collapse it and look around the tumor to look for, in this case, the 12th nerve. And then eventually we want to find the vertebral artery. The other way you can find it is to find the extracranial vertebral, the V3 segment, and follow it in to the dural entrance. But here's the tumor being peeled away. We're going to detach the tumor with sharp dissection. And more debulking of the tumor here. And then more detachment of the ventral attachment. And the vertebral artery will come into view here soon, so you have to be careful not to injure the vertebral artery. So there's the vertebral artery just underneath the tumor here. You can see this is where it enters the dura. So here we have the vertebral artery, and there's more tumor wrapped around the vertebral anteriorly. And so this is a C1 nerve rootlet here. We're just going to preserve this. It's probably not necessary, but I always try to preserve as much as I can. So if I cut the tumor in half, I can deliver the inferior pole and then bring the superior pole underneath the C1 rootlet here so that I have more working space. My corridor below C1 is larger, so it's easier to remove through a bigger corridor. So here's the last portion of the attachment. And so I'm going to look inside with an endoscope here in a moment. There's vertebral artery. Here's 11th nerve, C1. And here's the lower cranial nerves. And then there's the ventral clivus, completely detached. And we'll look at the endoscope. Look how the dural attachment is right next to the vertebral artery. So it can be treacherous to remove, and you can potentially injure the vertebral. And so very important to preserve all these structures. And so here's the final view. Here's a patch graft with alloderm. And then to prevent CSF pseudomeningocele, I'll put a little bit of fat graft over my dural repair, a very thin layer of fat. It's a nice technique. And then a little plate to secure it in place. So this prevents pseudomeningocele formation. And then here's the final view, excellent decompression of the brainstem, and she regained her motor function after this. And lastly, I just want to cover jugular foramen. This is another temporal bone type approach. This is the description of the approach. I had the privilege of writing up Dr. Fukushima's technique for this, but this is the technique I've adopted, where you do an exposure of the mastoid and the cervical portion. And then after the tumor removal, you have to preserve this medial wall of the jugular bulb to preserve the lower cranial nerve function. This is a case of a 51-year-old male with Vernet's syndrome. If you remember, Vernet's syndrome is 9, 10, and 11 palsies due to a jugular foramen lesion. He also had a 12th nerve palsy. You could see hemitongue atrophy. And what is this finding here on the right for the residents? This is a winged scapula. So you can get a winged scapula not only from long thoracic nerve, but also spinal accessory nerve palsy can give you winged scapula. So this is the MRI. You could see it's a bright T2 lesion in the lower clivus. And this is a large jugular foramen parapharyngeal chordoma. I would not advise endonasal endoscopic approach for this, but you need a lateral skull base approach. You can see the patient has spinal instability also. The occipital condyle has been completely destroyed. And so we'll use a lateral, anterolateral approach variant where we do an infralab mastoidectomy, skeletonize the sigmoid sinus. And here's the tumor completely eroding the occipital condyle. The tumor has been completely eroded, and we're going to expose the V3 segment of the vertebral artery in preparation for potential transposition of V3. And then there's the fallopian canal. I like to keep it in its bony fallopian bridge because it prevents it from any injury as opposed to a free soft tissue nerve. And so we'll occlude the sigmoid sinus and inject Surgiflow to prevent back bleeding from the inferior petrosal sinus. And then this allows me to open up the jugular bulb, the way that we would do for a glomus jugulare tumor. But in this case, this is a intrabulbar chordoma in the jugular bulb. We'll now go into the parapharyngeal space in the neck and then debulk the chordoma that's in the neck, retracting the carotid arteries posteriorly. And then we resect the rest of the internal jugular vein up to the jugular foramen. And then I'm drilling the remainder of what's left of the occipital condyle. It's just a eroded shark tooth of bone. And then we can remove the chordoma around the C1 ring. And now I'm drilling the lower clivus. The lower clivus is being drilled away. And then there's the tip of the odontoid by my suction. That is the tip of the odontoid. I can drill the tip of the odontoid, and I didn't have to transpose the vertebral artery. So I left the vertebral artery in place. We now go intradurally, and there's the ipsilateral vertebral artery. We skeletonize the vertebral artery and resect the tumor that's attached to the ventral clivus. These are the lower cranial nerves. In this case, they're all impaired and dysfunctional. So you can go ahead and divide them safely. And then this allows you to remove that last portion of the tumor attachment. There's the VB junction, the two vertebral arteries. And repair here is challenging. There's a large dural defect. We use a multi-layer approach. We cement off the entrance to the middle ear and put a fat graft and a lumbar drain and a Medport plate. And so here's the final removal, a near to gross total removal. And this patient had subsequent occipital cervical stabilization for the instability. And he had a preoperative tracheostomy and peg tube 1 month prior to surgery to optimize nutrition. And he did quite well and went on to radiotherapy. And the last case I'll show you here is a glomus tumor. You can see this is filling the jugular foramen and extending into the paropharyngeal space. This is a hypervascular tumor. You have to embolize these prior to surgery. You can see it's inside the venous channel. This is the internal jugular vein. So this is intraluminal. We're going to use the same approach, infralabyrinthine, transmastoid, transcervical, anterolateral approach. Here we're opening up the middle ear, and here's the exposure of the neck. There's the jugular vein that's tied off. So we're going to tie off the internal jugular vein, and we're going to open up the sigmoid sinus, and we're going to occlude the proximal sigmoid sinus intraluminally with gel foam, and then inject distally the Surgiflow, because we're controlling the back bleeding from the inferior petrosal sinus. And now we can identify the intraluminal portion of this tumor and then control the back bleeding, the venous back bleeding, with a little Surgiflow. And then here you can see there's the tumor. That's more vascular. This is the top of the jugular bulb that's being removed. You can see here's some coil mass from the embolization preoperatively. Here's some coil mass. And then when we take the tumor off of the jugular bulb, we're preserving the medial wall of the jugular bulb. This helps us preserve the lower cranial nerves. And we'll put a little Surgicel there for hemostasis. And one of the difficult aspects of the exposure is opening up the space between the jugular vein and the jugular bulb. And the key to do this is to identify the muscle called the rectus capitis lateralis. When you identify the rectus capitis lateralis, you can open up this area. And here's the tumor, the top of the tumor that's controlled. And then we're peeling it from the rest of the jugular vein. And then this tumor goes all the way down into the neck, and we've tied off the internal jugular vein. So now we're going to open up the lumen of the internal jugular vein and then identify the intraluminal portion of this tumor. And so this is nice and smooth and easily peeled away from the lumen of the jugular vein. And here's the last component of the tumor being removed. And there's the complete removal here. And those are the carotid artery. So this is all extracranial, extradural approach, no CSF leak, and a complete removal here. So I'll conclude here and say that maximal safe resection and cranial nerve preservation can be achieved. And while the retrosigmoid approach remains the workhorse for posterior fossa skull base, I think there remains a role for transpetrosal and transpetrous approaches, which are important in the armamentarium of skull base and vascular microsurgery. So sometimes this can provide some advantages, maybe a better angle of attack to the target. And I think you need to master the temporal bone. You need to master microsurgery, and we have to continue to preserve these techniques. Thank you very much, Professor Juha, for this opportunity to speak in your forum. I appreciate this time. Thank you very much.
Okay, excellent, James. Juha, you there?
Yeah, I'm here.
Okay.
I'm here.
Okay.
Thank you very much. Wonderful lecture, very good documentation of all the cases. And I think it's free for discussion, comments. I saw that in chat box, any questions or remarks? Can you find them?
Yeah, Harshad from Mumbai has a question. Harshad, you there?
Hi, John.
Yeah, go ahead, Harshad.
Yeah, excellent presentation. Wonderful videos, as always. Wonderful. I have a query saying about the trans-labyrinthine approach. Many times we are using this for the acoustic neurinoma patients. And what we have observed, of course, we take the help of our ENT colleagues to drill out the labyrinth and go to the dura and this. And the approach becomes slightly smaller than what we get in the retrosigmoid. When a tumor is larger and adherent to the brainstem, how do you manage to resect it out from the brainstem to prevent any injury to the brainstem? What is your approach to that?
Yeah, I think oftentimes there's a concern that the translabyrinthine window is small and the tumor is big, but
Yes.
actually you can maximize your corridor by you can put a little suture on the pre-sigmoid or dura and gently retract the sigmoid sinus posteriorly, and that gives you a little bit more room. And then you have to put a suture on the dura above, the leaflet above, to look up by the tentorium. But a lot of times as you debulk the tumor collapses, so that you have to work patiently, and as you sequentially collapse the tumor and come around it extracapsularly, you're bringing the tumor from the periphery down to the center of your exposure. And as you get closer to the brainstem, you use the same technique I described, using the subperineural technique, and then using sharp, fine microbayoneted forceps to separate the tumor from the brainstem. But I find that the translabyrinthine, it's a beautiful approach that takes you right on the brainstem, and you don't have to retract the cerebellum. You can avoid cerebellar retraction injury.
Yes, James, that is the biggest advantage of the translabyrinthine. You are straight away on the facial canal, and cerebellum is not even seen in that approach. And we start debulking. My concern was on a larger size tumor. Whenever we have done this approach, and we find little difficult to separate it out from the brainstem. But good suggestions to take stitches take some sutures near the sigmoid sinus to lift it out. Do you leave a island of the bone on a sigmoid sinus when you drill it, or completely bare it?
I prefer not to. I worry about the islands of bone that can cut into the sinus. So okay. I try not to, but sometimes you have to leave it if it's too adherent. But the important thing is you have to keep the sinus moist. So I use a bicol collagen substance to keep on the sinus, and you have to have your assistant irrigate it, because the light and the heat of the microscope dries the field. And correct. If sinus is dry, you can risk thrombosing it. And I always check with the microdoppler at the end of surgery to assess the patency of the sigmoid sinus. Very important.
That's very important. No, I have seen Professor Breckman doing that and leaving the island of the bone. Right. Nice presentation. Your videos are superb. I must admire that. And the best part is hardly any bleeding I see in acoustics, and most of the time we see a lot of bleeding occurring during surgery. Very nice.
Okay, we have a question from Danu Rolian, a neurosurgeon from Indonesia. Hello, Danu. Go ahead, unmute, Danu. Go ahead.
Hello, Dr. John. Hello, Professor Juha, Professor Victor, Professor Takashi, and all other distinguished speakers. It's a pleasure and a luxury to have Professor James Liu to explain a lot of skull-base surgery, especially in the petroclival meningioma and other modalities. My question is, what is your opinion about the preservation of the sinus pattern in the when we're going inside when we're going to and cut the superior petrosal sinus and superior petrosal vein? Do we have to concern the drainage pattern of the trollard and labae, and also the sinus cavernosus, considering all going into the superior petrosal sinus and to the jugular bulb. Do we have to learn it before surgery, or I think we can do it inside the OR and going inside when we getting into the intradura, because we see a lot of large petrosal vein and also lots of superior petrosal vein and superior petrosal sinus. We sometimes we are a little bit hesitate to cut the vein because we're afraid that the brain will swell and edema postoperatively. So please, Professor, thank you.
That's a very good question. The question is about how do you handle the venous anatomy to avoid venous infarction? And, like Professor Almefti taught us, the veins are so important. The Bermuda venous triangle, as he calls it. You have to, first and foremost, you have to preserve the sigmoid sinus, transverse sinus, and you have to preserve the veins, not one vein, but sometimes veins of Labbé, as they drain the temporal lobe and they join the transverse sigmoid junction. So when I'm opening the temporal lobe dura, I open the dura more posteriorly. So you go beyond the junction of the transverse sigmoid junction and you look for those veins, and I protect them with the bical, which is a collagen sponge, not gel foam. Gel foam, by the end of a long surgery, becomes very sticky and adherent. And when you try to remove it, it injures the soft tissue. But if you use bical, it's a very nice substance that you can irrigate and remove, and it doesn't stick to the tissues. So you keep the veins of Labbé protected. And the next important question is what about the superior petrosal sinus and superior petrosal vein? So I think it's important to do a vascular study before doing these approaches. You can do invasive angiogram or you could do non-invasive MRV, but look for the dominance of the sinus. And I luckily I haven't had any venous infarction ligating superior petrosal sinus, but I do try to preserve the superior petrosal vein if I can. So if you're cutting the tentorium, you can either decide to cut in front of it so that the drainage is still up into the tentorium, but sometimes you may have to divide it. But if I do divide the superior petrosal vein, the Dandy's vein, I typically divide it as close to the tentorium as possible. So you preserve usually there's two branches that before they make the main trunk, you can still preserve the flow on those two branches. So you have an alternate pathway of flow. If that makes sense.
Thank you, Professor.
Okay, we have a question. We don't have a name. The question is, what are the problems in post-op when the semicircular canals are compromised?
So you can certainly have hearing loss, if you compromise the semicircular canals. The idea for the transcrucial approach is that if you remove them and you wax off the membranous canal so you avoid leakage of the endolymph, you can potentially preserve hearing. And so there's an art to doing that, but certainly you can have the risk of sensory neural hearing loss. The good news is that if you keep the cochlear nerve intact anatomically, you have the option of cochlear implant later on after the post-op period. And we've done that for several patients who've had hearing loss, and it's a good option for some hearing restoration, something to keep in mind.
Okay, more comments, questions?
John?
Go ahead, Harshad.
What is this collagen material, Professor James? What do you think? What is this material which you use to protect the vein of Labbé?
It's called Bicol. Let me see if I can send it to the chat.
Yeah, please.
BICOL.
BI,
Yeah, BICOL, Bicol.
Bicol. What exactly is the material, by the way?
It's like a collagen sponge. I mean, it looks
Collagen.
like Duragen almost,
Oh,
but
Duragen. Okay.
but I think it's slightly different. I don't know the exact
Material,
variation, but it's a similar to a collagen sponge.
And it doesn't stick to the brain and feet.
No, it works beautifully. I use it to before I put a cottonoid patty. I usually use that because it doesn't stick.
Good idea. Good idea. We are using the different materials like gel foam, and sometimes I use the glove. I cut the glove, finger glove, and then I put it there so that it doesn't stick there. But this is a good idea. Thank you. Thank you.
Victor, do you have a comment or question?
Excellent lecture, Dr. James. Amazing videos. So it's not easy to make that kind of surgery in some countries, but we try to make that. For example, in Mexico, we have some fascial lesions and complete lesions sometimes when we try to get out gray tumors, giant tumors. What is your opinion in the reconstruction?
You got cut off after reconstruction. You mustn't. Can you repeat the question? What is your methods of reconstruction?
Yes, when we have a complete fascial lesion, you make a reconstruction after the surgery?
Yes.
Some after, for example, anastomosis between the hypoglossal with facial nerve?
Oh, okay. I believe the question is about facial nerve reconstruction options in the face of facial nerve injury. So if there's a facial nerve transection, your best option is a direct anastomosis end to end, or you can harvest sural nerve and do an interpositional facial nerve graft to attach the two ends. That's if you find the injury at the time of surgery, that is the best time to repair it, and you can get a good recovery of that. However, if you have a facial palsy and the nerve is intact, but it's injured severely, you mentioned the 12-7, the hypoglossal to facial nerve anastomosis, and that traditionally has been the alternate option, but you run the risk of having some tongue weakness. So a much better option nowadays is I work with my ENT facial plastic surgeon, and they can do a masseteric facial nerve transfer 5-7. So instead of 12-7, it's 5-7, and they can take the masseter branch, and what it does, it pulls up the midface very nicely. So it really makes this midface look quite nice. And I think that's been a game changer for facial reanimation options. So you should work with your ENT facial plastic surgeon. They can do a number of different creative grafting. And of course, if that doesn't work, there's always a gracilis muscle transfer, which is a little bit more complex. But again, that I think it emphasizes the need for collaboration with our ENT colleagues.
Juha, do you have any comments or questions?
I can only thank for excellent lecture, wonderful videos, great skills, and a lot of things to be learned.
Okay, very good. Okay, I'm sure James is busy. Do we have any closing comments or questions from the panel? Okay, I guess we'll close. Okay, Juha, what is the plan for next week? Do we have a plan yet?
Not yet.
Not yet.
I'm on holidays now, so we have to think.
You
Can we
finally-
do? I have to ask Subin what we are doing now in the next weeks.
You're finally traveling.
No traveling in China, no traveling. Heavy quarantines, 3 weeks quarantine. If you go somewhere, when you come back, you are 3 weeks in jail-like quarantine.
Strict quarantine, right? Okay, James, thank you very much. And thanks everyone for coming, and hang around after if you can network, if you want to network, if you're busy, on with your day. So thanks for coming, everyone, and we'll see you next week.
Okay.
Thank you very much.
Thank you,
Thank you,
James.
James.
Thank you.
Thank you, Dr. James. Thank you.
Thank you for your fantastic